Hey everyone, this is Hailey.
And I'm Laura.
And welcome to The Body Pod. Welcome back to The Body Pod, everyone. Today I have the pleasure of interviewing Dr. Jessica Shepard, who is a Chief Medical Officer at HERS. She is a board-certified OBGYN, a women's health, sexual wellness, and menopausal expert, and the founder of Sanctum Med and Wellness, as well as the author of Generation M, Living Well in Perimenopause and Menopause. So today you get to join me while I have a quick Q&A rapid fire session on all things menopause. Enjoy. Everyone is so excited for you. I mean, we have like all of these questions, and we gave away the Generation M book yesterday. And so super excited about that. I've loved seeing the progress of Generation M because you have just been like killing it on the Today Show, Good Morning America, like all of these things, which is just so incredible. So thank you for joining us. You know, you're my absolute favorite of all time.
You're my favorite.
And we absolutely I don't know why we aren't meeting, but we're meeting this year.
Yes. Oh yeah.
Before the end of the year.
Absolutely.
Yes. Okay. I'm going to get started on these so we can get you in and off to packing wherever you're going tomorrow. Where are you going tomorrow?
I'm going to Ibiza, Spain.
Weren't you just in Italy too? Someone's
got to go to these places and talk about menopause, you know.
Hey, sign me up for the gig. I mean, I'm all for it. So good thing that you're traveling. It's like work / really cool vacation place to go. So yeah. I love it. All right, we're going to get right into it. So first question, I have heard that doctors will prescribe low estrogen birth control to women in perimenopause when the woman has been suffering from some of the common perimenopause symptoms: poor sleep, mood change, low energy, brain fog, lack of libido. I also heard this is controversial because the pill is not hormone therapy, and women may get better results from hormone therapy than just the pill. If blocking the sperm is not a concern, should women in peri with these symptoms be looking at hormone therapy instead of the low estrogen pill?
Oh, I love this question. I actually answered it yesterday. So I was at Eudaimonia over the weekend, and I did 3 sessions just on HRT. And that was exactly one of the questions that we got. So I'm kind of going to back it up until the perimenopausal phase and exactly what it is and why it's actually a little bit more confusing than the menopausal phase. Because during perimenopause is where you have this roller coaster fluctuation of hormones. And with that fluctuation, you have estrogen that some days are really sky high, really low. And a lot of those fluctuations cause some of the symptoms that people start to have that we would typically categorize as menopausal symptoms. So hot flashes, night sweats, irritability. Obviously, you have your decrease in your muscle mass that starts to occur from your mid-30s. But these symptoms usually are going to be infrequent or not as maybe severe. The problem becomes because you're still menstruating, whereas in menopause, you are not menstruating, you still have estrogen and progesterone, which means that if you're still cycling and have a menstruation, you have the ability to potentially still get pregnant. Now, is that likelihood high? No, it decreases as you go through your 40s, but there's still that likelihood. Now, here comes the tricky part, is that birth control, yes, it does have synthetic forms of estrogen and progesterone in it, but what's its job? To prevent pregnancy. HRT is usually going to be more of a different form of estrogen and progesterone, but it's on a much lower level. So it does not prevent pregnancy. So that's why in the perimenopausal phase, it becomes a little bit confusing as, could I take OCPs? Absolutely, you could. Does it take care of some of the symptoms that are what we call menopausal symptoms? Yes. But the tricky part becomes, do I stay on it throughout my 40s into when I might be the least likely to get pregnant or I'm menopausal, or do I start HRT? So the way that I like to answer that question is, if you're still having symptoms And for a smattering of other reasons, say you're not sexually active, say you really have infrequent periods, or you're down to maybe minimal periods, and you're like, my risk of getting pregnant is really low. I would like to switch over to HRT to help with my symptoms and also booster my estrogen progesterone kind of scaffolding, which helps with longevity and bone and all of those other great things. But there are a lot of people that are relatively younger, maybe still have cycles regularly. I have 47-year-olds, I have 52-year-olds who have cycles regularly. And so to me, even though the likelihood is lower, they still are ovulating enough to a level to elicit a period, which means they're probably ovulating. So they're probably people that I'll be like, you know what, you can get benefit from both, but let's prevent pregnancy should maybe be prioritized than just looking at it from an HRT perspective. So the hormones in both of them are completely different and they do different things. So you do have to weigh where you are in the process, what you're looking for as an outcome, and then make a decision.
Oh, that was the best answer of the night, right at the top. Actually, I don't know. I haven't read them all. I read most of them. Okay, so for a perimenopausal woman who is already prone to waking up around 2 to 3 a.m., this is me. I didn't do this question, but this is me, but who definitely wakes up with hunger around 2 to 3 a.m. when in a calorie deficit, do you anticipate that adding progesterone at night might be helpful for better sleep?
Yes. So was the hunger part of the question or just the sleep?
I think they're saying that they also wake up if they're in a calorie deficit, but then they're waking up anyways if they're not.
Okay, so let's address it as just a pure sleep question, and maybe if there is more clarity on the hungry part, then I can address that. But there's multiple reasons why we have change in our sleep during the perimenopausal phase into the menopausal phase. And then again, has to do with the fluctuations. So we'll go back to that roller coaster ride that you're having where you don't have this great consistency in how your hormones are starting to show up. And so what happens, namely progesterone, which is, I like to call it our comfy hormone. It really like relaxes everything. It makes the GI relax. It makes your sphincters relax. Everything is just like so relaxed. So in addition to that it really does help relax you from a sleep perspective. And so when we start to have actually a really significant drop in progesterone during the perimenopausal phase, that's when it starts to impact not only from the comfy perspective of what it does, but also our circadian rhythm, right? And so our circadian rhythm is ever so important when we think about what it provides as far as time frames of when you're having when your brain is regulated to sleep, being sleep versus awake. But then you're also having now this disruption in your progesterone, which is also impacting how you're able to relax in that time frame. So because of that fluctuation and decrease in progesterone, it is actually a good idea to consider progesterone. And when I say that, it has to be not synthetic progestin, because that is the one that actually we don't like because it does have increased risk of breast cancer in that use, but a natural progesterone, which you can get from a regular pharmacy. So that can be your micronized form of progesterone in either a dose of 100, 200. Some people take a little bit higher, maybe 300. But we do see that because of that phase or that drop in the hormones, you're not going to have quite as much as the sleep that you like. Now, the other thing that occurs too is it impacts. So now you have estrogen starting to decrease, which doesn't take as much as a dive as progesterone throughout the perimenopausal phase. But because estrogen decreases, a lot of people then have night sweats, because that's where we get a lot of our hot flashes and night sweats, is because of the decrease in estrogen. But even if you don't notably have a night sweat, we have a lot of good data that shows that even if it's not visibly waking you up and you're sweating, that people actually do experience night sweats or hot flashes at night but it's not the typical one, but it's still enough to wake them out of their sleep. So a good way to start, especially if someone's hesitant about going on HRT or the estrogen part of it, is actually just to start with a progesterone compound, and also to start magnesium as well. Magnesium is a beautiful way for you to kind of get that regulation back with your sleep habits. So those are two good things that you can put into your routine when it comes to sleep.
Oh, I'm getting on the progesterone because my sleep is not good.
Yeah.
And I do all the right things. I try to like turn off the phone and, it's just a doozy.
And so you're still getting kind of the awakening, right?
Yes.
Yeah.
Every time. And then I'm just like, should I get up and work?
No.
2:33. So
Don't do it.
Eventually I go back to sleep, but it's a doozy. Can you please give possible causes of postmenopausal bleeding and suggestions on how to stop it?
Yeah. Postmenopausal bleeding is definitely one of those things as an OBGYN that really concerns or alerts us. Okay. It's something that when someone says that, immediately we're like, but why? Why are they bleeding if they've experienced menopause? So menopause technically means you've gone 12 months consecutively without a cycle. Consecutively is important because some people will not have a period for 10 months and then they'll have a cycle. And I'm like, we have to start the clock again. So unless it's 12 months consecutively that you have not had a cycle, then that's menopause. Like that is the hallmark in the start. And thereafter, you should not ever have any more bleeding. So if you do have bleeding after that, it is really important that you talk to your OBGYN about that, because we need to know, why is your endometrial lining causing bleeding if your ovaries are not giving us enough estrogen to cause a cycle? So there should be no bleeding at all. So it's very important that you talk to your doctor about that. The caveat to that is that if someone is on actual HRT with a form of estrogen in it, it may cause a bleed. That is not a bleed of your uterus, but the estrogen that you're on is causing the bleed. But it's also important to still talk to your doctor about it, because then we can at least put into the equation, well, she is on HRT with an estrogen component on it. Could it be the estrogen that's eliciting this bleed? And we can figure out, through ultrasound, we can see if it resolves on its own. We can decrease your level of estrogen if you're on HRT. But if you're not, then we definitely have to look into that as a reason of why. So both of them are still very important, but two different reasons why you might have bleeding. End story is, if you have bleeding after menopause, absolutely, categorically do not hesitate and go see your OBGYN.
Okay. Does the next question kind of piggybacks off of that? Can vaginal estrogen cause postmenopausal bleeding? Is that a reason?
Yeah. It can. And the reason is we have estrogen receptors all over our body. I think we do typecast it to just being in the pelvis, specifically the vagina, but we have it in our bone, our brain, our heart, our muscle. So because it's very sensitive, obviously within the pelvic region, especially the vagina, because that's what allowed the vagina to have secretions when we were younger in our kind of reproductive phase. Like think about it when you have a baby and the baby gets all the way through the birth canal, and then when it comes out, it goes back down to size. So that's the flexibility and distensibility of the actual vagina. Estrogen has a lot to do with that. So now when we lose our estrogen and our vagina doesn't have the ability to be distends, it becomes more fragile, the tissue becomes more fragile. And now you start vaginal estrogen, the receptors are like, thank you. Thank you so much for pouring this estrogen into the area that we really do love. And it helps the vaginal tissue thrive. So if you have vaginal bleeding after, still another reason to go to your OBGYN and get it checked out. It doesn't necessarily mean that you have to come off of your HRT or your vaginal source of estrogen. We just want to make sure. We are definitely providers or professionals that want to rule out worst case scenario. So we will always be like, what caused the bleeding? And if we can make sure that it's nothing that has to do with anything that we're concerned about, then we feel better and we can manage it that way.
That's a great answer. Moving on to the bladder. How does the bladder change during perimenopause? I feel as though it is smaller. I need to go to the bathroom way more often, and the amount isn't as much as I used to be able to hold. This is me all the time too. Not my question, but this is me.
Yes, there is a lot in the pelvis that responds to estrogen. And the bladder actually is a very beautiful part of the pelvis. A lot of times it's forgotten because it doesn't seem like it's part of the uterus, vagina, and ovaries. But it really does have sensitivity to both progesterone and estrogen. But the same type of thing that I talked about in the vagina happens with the bladder. So as we start to age, it doesn't, the distensibility and the capacity for it to hold urine is not as much. It obviously, the sphincter, so the part that closes when you're not urinating and then that opens when you do want to urinate, it gets a little bit looser, right? So now you have incontinence issue with leaking because the stop cock is not there as well. And then the other thing is that estrogen really has the ability to, or control of the actual bladder. So it's smaller, it does not hold as much. And so if you think about during the night, a lot of times that's usually when, your bladder usually will capacitate a lot more as you're in rest. And then when you get up, usually after maybe 8 hours or however long you sleep, then you do have to use a bathroom. But if it can't go as big as it used to and hold as well as it used to, that again is why we start to have more issues with our bladder and having to have decreased time in the times between we need to urinate as we used to before. The other thing that I will say is we don't typically work out our pelvis, right? So when I think of a pelvic physical therapist, which helps us with our bladder and our control of our bladder, most women have never been taught how to do really good pelvic exercises to strengthen their pelvic bowl. And so as we get older and this starts to happen, we don't know how to kind of control it and keep it to do what we would like it to do. And then on top of that, think of what usually happens. We have pregnancies, then, even whether it's C-section or vaginal delivery, childbirth plays a lot of like trauma on the bladder. And so over time, it just gets a little bit weaker. And it is, quite frankly, when I used to do a lot of surgery, it's a kind of lazy organ. It just likes to forget what it does. It's like, what were we doing again? I don't know. So it is a little lazy, but I will give it some slack in that the estrogen makes it smaller.
Okay, good to know. So I am using estrogel for 12 days a month and a testosterone gel. I still get mood swings despite this routine. Is this something that can be changed with dose increases?
So tell me how long they're on the estrogel.
12 days.
Yes. Okay. So when we think of hormone replacement therapy, there are reasons why people can take it cyclic, which is exactly what you described, taking it 12 or 14 days, depending on how someone prescribes it, or you could just take it all the way through. So I'm going to answer the question as if they're perimenopausal and menopausal. In the perimenopausal phase, because we're doing that whole kind of roller coaster thing, sometimes it is a little bit hard to figure out where your fluctuations are. And if you're not on estrogen for the other remaining days, what's happening during those days as well. You still may be having these fluctuations, and that can be contributing to the actual, it can be contributing to the actual kind of frustration, irritability, because you don't know where you're controlling. It's still just kind of all over the place, where it was a little bit more predictable earlier in our, teens, 20s, and 30s, because it followed the regimen, it followed the schedule. Now it's just like erratic all over the place. And then the other reason is that in a continuous fashion, sometimes it is better to try and convert to continuous fashion, because then whatever you're on, whatever dosage you're on, can really be there to kind of buffer those fluctuations and keep the stability of the levels of hormones. So for someone who is taking a cyclic form of the HRT in the gel form, I think it's worth a try or a shot to maybe just do it continuously to see what the outcome is. Because there's no harm in taking it continuously during cyclic. It's just how it was prescribed that maybe that was thought it could be done in that fashion. But I think a good way to test, if you're going to have these kind of dips, is just to try a continuous form, obviously with the advice of your doctor and what dose you're on and figuring that out, and seeing if you can actually eliminate those moments and where you have the irritability.
I mean, all of this, there's so many different options that you can use for this.
I would say at the end of all of this is for everyone on here to realize that however they're taking it, or if they're not taking it, or if there's always options.
Mm-hmm.
That's,
Oh, I love that.
yeah.
For postmenopausal women wanting to use progesterone cream alone, no estrogen, for sleep benefits, what are the FDA approved options for progesterone cream that you would recommend discussing with our healthcare provider?
Yeah, progesterone cream. So what we have in, I guess you could say, in a pharmacy fashion, in what pharmaceutical companies, usually they will be in a pill form. Now, for a cream, usually it is a bioidentical form. It could be compounded, and so that you can actually titrate the amounts differently because it is compounded. What I would say is that because you're doing it in that fashion versus just estrogen alone, it is much safer. So I said this yesterday, every woman who decides if they want to take HRT, if you have a uterus, you must take progesterone if you're taking estrogen. If you don't have a uterus, that's the only time you have the luxury of saying, I would like to take estrogen alone. And the reason is because they balance each other out. And if you only take estrogen and have a uterus, the lining in your uterus will build and build and build, and it can potentially become endometrial cancer because progesterone's not there to equal it out. And so progesterone, however, you can take alone without estrogen. But progesterone and estrogen, if estrogen's taken, you must take progesterone if you have a uterus. So with the cream, there's usually going to be in a compounded version of how you take it. And it is very safe. I think it's like, I always say, it's like one of the best ways to test HRT if you're a little bit hesitant about it. It really is like the cutesy type of benign or friendly type of hormone. You know, like for people who are just like, oh, I don't know if I should do HRT. Progesterone really is that one that you can try in a cream form and get that compounded as well. And there's different levels of it as well. There's different dosages as well. I hope I'm answering that question in the right way. The other thing too is that I just, as I'm thinking through the answer, there are a lot of progesterone creams that you can get over the counter. Like if you go to because it can be made with yams, right? So in my head, I'm thinking that's where this question may have come from, because there's ones that actually are the bioidentical forms of the hormones in your body, which would be prescribed. And then those that people can try and make from wild yams so that it can replicate to some degree what progesterone can do, but it will never be as strong as what something is compounded and made in an actual pharmacy or a compounding pharmacy and actually made from a chemical form. So you may get relief from the ones over the counter, but there are some people who may try that and not get the relief they're looking for and may need to transition into more of a prescribed progesterone.
Okay.
Yeah.
What are the most important biomarkers for an active postmenopausal woman to monitor for maintaining health at this stage in life? Which specific blood work markers, percent muscle mass or body fat percentage? Do you have any?
Yeah. So when patients come into my office, to me, the menopause transition is much more than just the reproductive hormone portion of it. That's obviously a big part of it because it's the ovaries that have declined in their ability to do what they do. And so we do have our estrogen and our progesterone that we can monitor through that, as well as your testosterone. But you also have progesterone and testosterone that come from your adrenals, but most of your estrogen does come from your ovaries. So those three obviously are ones that we're going to look at. And then we'll look at the hormones that tell those ones to release, which would be your follicle stimulating hormone, which is your FSH, and then your luteinizing hormone. Are they as important? No, but they're good to include in those to kind of see where those are as well. I always look at thyroid, and I look at a full panel of thyroid because hormones are chemical messengers, and they like to talk to each other and tell. It's a symphony. Everyone's telling everyone what to do and where to be and how to show up. And if you basically have a portion of the symphony, that's playing bad notes and sounds horrible, everyone knows and everyone kind of is noticing that. So thyroid is, it's a small little gland in your neck, but it really does have a lot of responsibility. So a full thyroid panel, in addition to the other ones I just said. I also look at your lipid panel. So because estrogen is decreasing over this time frame, it actually triggers, remember we said estrogen receptors are all over your body. So there are a lot of features that occur as you're starting to age with your lipids, and those start to increase and sometimes do some funny things as well. So a lipid profile is also very helpful to make sure you're not increasing some of your triglycerides, or your total cholesterol, to watch that as well. Another test that's also important is your hemoglobin A1C. Your hemoglobin A1C is a lab that we draw that helps us to tell if you're going towards a pre-diabetic or a diabetic stage. We know that as we age and estrogen starts to go down, our body starts to have more insulin resistance. And one good way to make sure that we're not becoming completely insulin resistant is to make sure that our sugar is not creeping up. And that is a better range than just taking a random sugar, which can be on a lab, and testing over the last 3 months what it's been looking like in your system. So hemoglobin A1C, I also recommend that women ask for maybe an EKG to just see the functionality of their heart. It's such an easy way to just look at the functionality of your heart and what's going on. And then one more thing that I'll mention, it's called ApoB, APO, and then a big B. And that is, again, a key factor in determining someone's risk in cardiovascular disease. And basically, it's a protein that kind of facilitates and transports lipids. So if you, again, have an issue with your ApoB, that means that your lipids may not be getting to where they need to go to. It can be kind of increasing the plaque that forms in your vessels, which may contribute to cardiovascular disease. So again, that's another one that can be included in a blood test to kind of help, because number one killer of women is heart disease, right? A lot of times we think it's breast cancer or we think it's something else, but it's actually heart disease. So we really have to take care of our hearts, especially as we start to go through menopause.
Perfect. So is it, what is the difference between using combined pill, staying on it, versus switching to MHT? Are the hormones the same? Oh, we talked about this.
Yeah, they're different.
I'm 52 and have been on OCP since 18 and was planning to just stay on it until 55, then switch, but MHT is more appropriate. So really that you covered that of what we should do at the first.
Yeah.
If
I would make a strong disclaimer for someone. For me, typically this is personal, over the age of 35, birth control pills, I'm like, okay, how much longer do we have to stay on this? Can we find another way? Even if it's for birth control, I'll try to find other modalities of birth control. We did definitely. So there's nothing wrong that was done. We definitely have used birth control pills for decades as a form of MHT. We now are much better educated and understanding of the different types, why it's needed, what levels are needed for us to, I think, get more women off of birth control. To me, typically the latest, maybe mid 40s, early 40s for me, even if I can get them on another kind of birth control. But at that age, at 50, 52, 55, I would not wait till 55 to switch and just get off of it now and switch to MHT.
Okay, perfect. Yeah. Do you ever recommend hormone replacement for women, in perimenopause? So at what age? My testosterone is super low and my doctor recommended a testosterone supplement. I'd never heard of before. A troche?
A troche. Yeah, so it's a troche. It's basically like it looks like a pill, but you put it in your gum and it dissolves. So you get what we call like sublingual release of whatever it is. I mean, anything can be in a troche. It can be a medication. It can be a hormone. So ask the question again, because now I forgot. I just
so do you recommend HRT in perimenopause? And if so, what age? And then her testosterone is super low, but her doctor recommended a testosterone troche, something that she had never heard before.
Okay. So back to the question about when to start. It kind of goes back to the question of the birth control pill. In when is that time that you're perimenopause, which is usually your 40s, early
Mhm.
50s for some, because they still may be menstruating, is I need to sit and think about if I would like to stay on birth control, if I'm very sexually active and there's a good possibility I could have a uh-oh baby, right? Because then that makes, to me, it prioritizes birth control over MHT.
Mhm.
Do I have frequent cycles, infrequent cycles? Which again is going to go to, is it likely for me to get pregnant or very, very unlikely for me to get pregnant? And I can transition over to hormone replacement therapy. So those are like, everyone's going to have a different answer.
Mhm.
Choking. Um, so it's important to know who you are and what you're looking for.
Mhm.
I'm going to drink water.
Yes, drink some water. I'll get to our next question.
No, but
Um,
we didn't do the Troshi one.
oh, okay. Let's hit that first.
So testosterone is fine to take as HRT. I don't have a problem with taking it that way. There's various ways to take it. You could take it that way. Some injection. I'm not a fan of the injection. You can do testosterone creams and then also testosterone pellet. So there's various ways. Yeah, there's nothing wrong with that modality.
Okay, great. Moving on to what are your thoughts on Meridyne Live vibration plate for osteoporosis and or overall health?
Can you spell that?
MARODYNE vibration plate. Maybe just a vibration.
Yes. The vibe. I'm doing really good on this. So that really what it is to create low density vibration to help with stability, to help with flexibility. Would I say, I wouldn't say it's bad, but is it evidence-based as a form in a way to improve osteoporosis? I would put it more in the category of a supplementary way to improve bone mineral density.
Mm-hmm.
Ways that you're going to improve your bone health from a bone mineral density is resistance training. So weight training and also increasing your protein intake and also HRT. Hormone replacement therapy has been proven from the estrogen portion to improve bone mineral density. So it's not like it's a bad thing, but maybe put it on the list of things in addition to the other thing that I mentioned, then making it maybe the only thing that you're doing, thinking it's going to just magnify your bone mineral density to the level of what you could get if you were doing those other things.
Okay. I have Hashimoto's and wonder about all the conflicting information I read about whether or not to do high intensity exercises. I always think working at my best level is best. For example, lifting the heaviest, I can go with good form. What is optimal for people with autoimmune issues? Do you have a take on that?
Yeah, so that's a multi-layer question. I think when we think of Hashimoto's, right? So a lot of that has to do with it's an autoimmune disease, meaning that your actual thyroid is attacking its own organ, right? So the goal with that is to manage how to get the thyroid levels back into a normal range, which sometimes may need medication, which is okay. But there are other ways that you can, I guess, facilitate the Hashimoto's. And a lot of that actually can be with diet. And then if you think about it, most women will have thyroid issues after the age of 40. And a lot of that has to do with starting with the fluctuations in their reproductive hormones, namely estrogen and testosterone. Remember, you're talking about the symphony, and so one is out of place, and so it causes a lot of other things to be out of place as well. So that's why when we look at thyroid, that's why I draw thyroid on the panel when I'm consulting women about perimenopause and menopause. So a lot of times you can be correcting one and the other one starts to fall back into place. Does that make sense? And so I think a lot of women have had Hashimoto's or Graves' disease or whatever it is. And yes, it's a chronic autoimmune disease, but a lot of times it's missed by maybe if I start correcting the hormones of estrogen and progesterone slowly, we can start to see them equal out and not have as much of an issue. So when it now comes to working out, I'm trying to answer the question as how I'm hearing it, is that going overboard, will that impact the Hashimoto's thyroiditis, or if that could be done? Yes, I think working out always is going to decrease inflammation. And when you think about a chronic autoimmune disease, it has a lot to do with inflammation as well. So I don't quite know where in the question where it meant like working out too hard versus at your level. I think
Yeah.
obviously the best place to start is at your level. Another thing to do it to being like, let me do a full review of my hormone panel and seeing if there's anything that we could do from the reproductive phase of the HRT that might help with the thyroid function. And then also with your food as well. I do think that there are very holistic ways in which people can have their food or their nutrition support an autoimmune or anti-inflammatory through diet. Because our gut is a big part as well as what lets things in and out and what things may be contributing to this autoimmune type of disease. And so I think that there are wonderful functional nutritionists out there that kind of help look at the big picture and then help from a nutritional standpoint figure out what's going to help that issue the most.
That's great. So for someone that is on HRT, they're 55, how many years, if not for my lifetime, would you recommend staying on?
Yes, this is a very controversial question because of where we are currently in hormone literature. Have been for the last 20 years fixated on a study that really had us running away from hormones and thinking that they're bad. And we're now just on the other side of it in the sense of hormones are not that bad. They're not bad at all. They're actually very beneficial. So there were a lot of recommendations that were made with that study 20 years ago. And one of them was stop taking HRT at 10 years at the time you're menopausal. So if you stopped having periods at 52, 55, then you just add 10. That's when you stop. Or no longer than 60 years old, right? Whichever whichever pertains to your issue or your age. The problem with that is that we know from literature, the moment you remove estrogen, progesterone, and testosterone from your body that have been there your entire life, then your organs are also going to take a hit because they're not being substantiated by the hormones. So we're just at this early state of research to say, how long should women go on? There are a very big body of doctors that are like, from a longevity standpoint, why would I go off hormones? Because it helps bone mineral density, decreasing rate of Alzheimer's, decreasing rate of breaking your bone, improving your muscle mass. And so it's more now as we start to age, how can I thrive while I'm aging? And hormones have a lot to do with that. But also we have strict recommendations based on studies that are like, well, we really shouldn't go past this point. Where do we think that we're going with research is more towards, I'm going to be on hormones until you desire to or until you die. And I think when you have a really good conversation with someone who truly understands hormones, people should be able to make the decisions that they want to based on the information that they get. Nowadays,
Absolutely.
we're still in that phase where they're going to be like, oh my gosh, you are 62 and you're still on MHT. We've got to get you off. I have patients who are 70 and they're like, I feel great. I'm not coming off my hormones. And I'm like, rock on.
Yeah.
So again, people really need to get to the point where they're like, of all this stuff with risk and benefit. And what I'm looking for is I'm looking at my life in my 60s, 70s, and 80s, 90s. What I want that to look like. How is this helping? How may it not? As we age is probably the risk factor for most diseases, breast cancer, heart disease, Alzheimer's. So as we age anyway, things are going to start to not function as properly. Disease goes up. But if you were to think of it in a way that says, I want to be able to be exposed to hormones to give me the best benefit as I age and quality of life, that's another way to look at it. But no one's wrong, right? You get to determine which one of those works best for you. And I think that we're going to start to see that it is more personalized as far as a medicine form to saying there's going to be a risk at every point. Which
Yeah.
are you willing to take personally?
I love that. Okay, so what do you recommend to your patients with osteopenia? Estrogen, HRT as a prevention for further bone protection or bone loss? And what about creatine?
Back up on that question again. Start with the first part.
What do you recommend to your patients with osteopenia? Would you do HRT therapy as well to prevent further bone loss or for bone protection?
Both. You can see considerable amount of improvement in bone mineral density levels and scores, if you're to look at it from a DEXA scan perspective, when people are on estrogen. That has been stated clearly in the literature. So if you have osteopenia, which is a deficiency, not a deficit, then I would love if someone was like, you know what, let me give it my best shot of not becoming osteoporotic and go on MHT, do my strength training so I can be more preventative and actually improve my bone mineral density. Yes.
And also with HRT for all of these, like that's never going to replace strength training. Like we have to do those hand in hand.
Yes, because they're by different mechanisms in which they're improving the bone. So for example, with MHT, the estrogen is improving the bone mineral density by improving the osteoclast, which is the cells that make our bones stronger.
Mm-hmm.
With resistance training, what you're actually doing is it's kind of like a domino effect. You're triggering your muscles through its fibers as it's kind of doing its twitch to then tell the cells on the bone to improve or to become more or to build more. Right. So they're both different mechanisms. So you're going to get the best benefit from doing both. But, you know, I have patients who have never weight trained or they're scared to weight train. I'm like, well, let's at least start with some estrogen or vice versa. Mm-hmm. Right. So it's never to say that everyone's always going to have the perfect template of what they're doing, but at least being able to do one, if not both, is the best way to improve your bone.
Yes, I love that. Okay, what is the best non-pharmaceutical intervention to protect and build bone for postmenopausal women diagnosed with osteopenia?
Weight training. It's not a medicine. I mean, it's not a prescription.
There you go.
Exercise is medicine, but that one's not a drug.
Yeah. Perfect.
That's far the best way to do it.
So if someone was a little bit weird about x-rays, how safe are DEXA scans in regard to radiation exposure, and how often is it appropriate to get them done?
So, and this is a good question too that I had yesterday. So when we look at radiation, when we look at it from a RADS perspective, that's how we monitor the amount that you're getting exposed to. DEXA scan is really low on that list, and even X-rays. And when we think about like exposure to radiation and like the likelihood of cancer, it really is for people who are getting like significant amounts of radiation like every day for like 2 years. You know what I mean? A lot of the data that came out on radiation and cancer, one, it was done on mice, which obviously were not big mice, but it's a good indication of what can happen. But when you actually look at the studies, it was a significant amount of radiation. So in an everyday person's life who's like, I'm just doing this imaging occasionally, with which a DEXA scan, let me finish my statement, because I'll go back to recommendations for DEXA and how often to do it. But it really requires a lot of exposure to radiation for someone to say, oh my gosh, I got a cancer from actual, right? Okay, so I want to reassure everyone with that. The other thing about DEXA scans, currently the recommendations for DEXA scan by insurance is not until the age of 65, which I completely hate, because what do you think's happened by the age of 65? Our bones are like, we were already on our way out. Like, and so it's not a very preventative way in the way the recommendations are written about DEXA scan, the way that we use it. So amount of radiation is very low. currently the recommendations at the age of 65, to me, I'm just like, of course women are going to be, they've been usually menopausal for at that point, like 15 years without any estrogen. And most of them are not taught to weight train. So of course their bones are not doing great.
Yeah.
So when you think of physicians, they're again, a circle of physicians, not to say that it's little, but outside of the traditional setting, who use DEXA scan not only to look at your bones earlier, so they might recommend someone to go get it like in their latter 40s, early 50s, as they're going through that transition into menopause, because now they're losing estrogen. But also, DEXA scans are a beautiful way to look at your lean muscle mass and your actual fat capacity as well. And the reason why that is also important is because your muscle mass too is significantly decreasing over that menopausal, that perimenopause, menopausal timeframe. So now your estrogen's going down. That's what I'm saying. Estrogen receptors all over. Impacts your bone mineral density. Your muscle mass is starting to go down as well. But your fat cells as well, how they respond to estrogen is they're not as agile and shrink as well as they used to before, which is why we start to change our body composition as we start to age. So DEXA scan is actually a beautiful way to look at multiple things and to help people being a little bit more visual to what's going on internally in their body, so they can start to make the changes and the connections in their head and being like, oh my gosh, look at my muscle mass. And
Yeah.
so they're actually, if you go find DEXA scanned facilities, they're actually not that expensive. They're like $125 to $150. And if someone wanted to get a good baseline on what their body's doing internally from a muscle perspective, a bone perspective, and kind of like a fat or a muscle fat ratio, DEXA scan's a beautiful way to see that. It also can be preventative because now you know what your bone mineral density is at a younger age. And if you wanted to, you could do it every year. You could do it every 2 years, but it's a great way to see so much more than what we used it for, and much earlier is better.
Yes. Okay. Would you recommend somebody going on our HRT that's not having any symptoms? Still has a period and perimenopause, but like doesn't have any headaches? No, nothing.
Mm-hmm.
Yes, you would recommend it.
The reason why is this is a very controversial question right now, because typically we used to wait for women to be menopausal before we would give you MHT. We are moving away from that. And still a lot of providers, and again, not to say that they're wrong, but this is how we were trained, we would say, well, we'll only put you on MHT if you have a symptom.
Mm.
But what do we know happens when you're just declining from estrogen anyway? So many things in your body. It's not always a symptom. So I think that there are providers who will do it. I think that women need to think about those decisions when they sit down and think, am I having a symptom versus am I improving quality of life and longevity? Those are two different things.
Yeah.
And you can actually get the benefit of both when you use MHT. And so approaching it from that way rather than I'm only going to go on MHT when I have symptoms. And I really want to make a disclaimer that I'm, as much as a HRT advocate that I am, it does not mean that if you're not on it, then you should be shamed because you didn't go on it. I just want everyone to have the ability to know really good fundamental information. So when they make the decision that they would like to or not, as much as I could be like, I think it's the best thing for you. If you choose not to, then you choose not to.
Yeah. This is why I love you, because I feel like your energy and your candor is just so spot on. Like it's not harsh either way. Like it's just, here's the information as a physician. And you get to make the choice.
Say you change your mind in 3 years just because of the information you heard and you just gave it more thought and you had more conversations, right? All of this is really now to get people to then go and being like, I didn't know that about. Let me talk more about it to my friends. Let me bring it up to my doctor. And that's how we change the ability for us to make decisions, is because we're changing our conversation.
Yeah. 100%. Oh, okay. I love it. So I'm someone who is in the age range of perimenopause, 42, but hasn't experienced any trouble except for a bit of let's talk about the visceral fat, because there's a few questions here with that, but no other symptoms. and have heard that women should do hormone testing before menopause so that they have baseline levels of hormones to aim with HRT if they choose that route in the future. Should I consider checking my hormones at this point anyway, or wait until I have further symptoms? If hormone testing is recommended, do you have a recommendation for the test? You went over the test, so we'll cover those.
Yeah. So what your hormones are doing today at what time? Well, at my time at 6:57 will be different than if I tested them today at 2 a.m. or tomorrow morning, right? And so it's not so much a matter of if I draw it now, will it help me later? It's good to have a baseline to see where you were, but it should not dictate what your dosage of MHT is going to be now or in the future. So it's not so much for, I have to do it now so I know my dosage will be later. I think that it is good for people to get a baseline, just to have a baseline. And if we decide if you have symptoms in 2 years, or if you're like, let me see what my hormones are in 2 years, you can kind of see what that difference would be, but it doesn't necessarily mean that it should dictate your dosage. I want to make sure that people understand that. Then the other thing is you asked a second part of the question. It was about we went over what should be drawn on the labs, and you said something about visceral fat.
Yeah, does the visceral fat, so this is the only symptom that they're having, but then someone else had mentioned, the weight gain with visceral fat, and how realistic is it for perimenopausal women to achieve fat loss, weight loss? Is there hope, and does HRT help with that?
Yes. So I'll answer the first question first about visceral fat. So you have your peripheral and subcutaneous fat, which is the fat that we see, right? So it's the fat that migrates. It used to be on your hips and your butt, and now it moves to your abdomen, even though you didn't ask it to go there. And then you have visceral fat. Visceral fat we can't see. I have seen visceral fat because I went into someone's organs and looked at it with a laparoscope, or I cut them open and was doing a surgery. It's the fat that you see around an organ. And the fat that's around an organ is for protective reasons. But what happens as we start to get older is that our visceral fat starts to increase. Okay. So that and becomes a problem. And that's also what you can see on a DEXA scan as well, your visceral fat, which we can't see just looking at someone externally. So the reason why visceral fat is important, because you won't feel when it's increasing, you won't see when it's increasing, but it does impact your organ systems, okay? And so that's why people start to maybe have like liver issues or heart issues or whatever. That's a reason why. Weight loss in general will always be one of those biological features that for some people may be more than others, but in general, everyone will start to have weight increase as they age because of insulin resistance. The main bulk of why we start to see that happen is because estrogen decreases and we start to have a shift in our muscle mass, right? So if you think of a pie chart, and for your 20s and 30s, and when you're an adolescent and really active and your muscles are very, very, they're thriving, they may take up 65% of the pie. And then you have organs and water weight and fat, which take up the other portion. As we start to get older, that 65% of that pie starts to decrease slowly over time. So what does that allow more space for? More fat, right? And so now we have decrease in estrogen, which is also not helping our muscles. We have a decrease in testosterone, which is also not helping us build more muscle. So hormone replacement therapy, in essence, is not directly making you lose weight. It's helping all of the things that were there, part of that symphony, to kind of keep everything in check, increase your muscle mass through testosterone. But then the work comes with bulking up your muscle, because you're already losing it. So you need to bulk it up to get that pie chart back to what it used to be. And that's why when I see your program, it's so phenomenal, because weight training is really saving lives, because muscle is the organ of longevity. It's the thing that keeps us stable. It's the thing that keeps us strong. It's the thing that protects a lot of our bones and also our heart. And that is why it's important to switch to more of a weight training workout than ever when you're going through that phase. We're really trying to get that 65% back, right? And I'm just
Yeah.
using arbitrary numbers, but I'm just trying to give you like a kind of visual of what's happening with your body. The insulin
Yes.
resistance part is also crucial because it's not anything that you can see. It's really just this thing that's happening internally. And when you start to have increase in insulin resistance, that means it's like a mailman. I always say this. The insulin's like the mailman. It distributes the sugar where it needs to go. And it's like you are fuel, you're going to the brain. So the brain can use you. The liver needs you, the muscle needs you, all of these things. But as we're more insulin resistant, as we start to age, the mailman's like, yeah, I'm not doing the mail today. And then the mail's just sitting around and the sugar is like, we have nowhere to go. And so it just sits in our blood. And then we
Yeah.
become more diabetic in a more diabetic phase. But the reason why I love your program again is because the biggest utilizer of glucose is muscle. So if we're not building muscle and it's already on its way down biologically, the sugar is just going to be like, well, we'll just sit here too because we're having fun. And then it converts to fat.
Yes.
Yeah.
Oh, and to answer the rest of this question, yes, you can absolutely lose fat in menopause and perimenopause.
Yeah, and I know you
All
know
the
that as
time.
well. Is it easy? I will go on brand and say, is it easy? No. Can it be done? Yes.
Yes, absolutely. Okay, we're gonna rapid fire these questions because you got to get off. You got a trip to pack for.
I mean, it's only Ibiza.
Will you please? I can't wait to watch all of your stories. Okay, as menopausal women not on HRT, our libido decreases and orgasms may take longer to achieve. Considering a happy, healthy sexual relationship exists, what natural supplements or adaptogens can you recommend for this that isn't HRT?
Yes, vitamin B12. There's a medication called Addyi, Eaddye. That's helpful. Vyleesi is also a helpful medication that helps with it. I definitely am. There's it's a niacin. It's a little. It's over the counter, but it's a little gel that you can put on your clitoris, increasing and enhancing. PRP injections, O shots, they do help. I really do like those. There's so many other ways than taking testosterone. But when it comes to libido, all I would say is women do not let that go. We are entitled to pleasure. We are entitled to having really fulfilling lives as we grow older. Do not let that go.
Yes, agree. Mic drop. Okay, would you suggest, okay, so we talked about if somebody was just having hot flashes, would you suggest to stay on HRT after 60? I guess that goes back to quality of life of what you want.
Quality of life, but I'm going to give a very big nod to yes, because I have patients who are in 70 and having hot flashes. Like, I can't tell your hot flashes to stop, right? I would love if they weren't there, but if they're still there, you need estrogen.
Yeah.
And progesterone in the uterus.
Yes, yes. That I learned that from tonight. So that was new to me. Okay. What do we know about safety of oral micronized progesterone compared to progestin? Is it associated to breast cancer or cardiovascular diseases or any other risks?
Very easy answer. Progestins, please just don't take those. Those are what in that study 20 years ago increased risk of breast cancer. So those are synthetic. Really look at your micronized progesterone and stick with that. Yeah.
Okay. Awesome. What are your thoughts on estrogen products for the face? Do they work to improve the skin and are they safe?
Yeah, so they are safe. It's estriol, which is a weaker form of estrogen. So it's not like it's getting absorbed in your face, and it's in small amounts. It's not getting absorbed and it's going to course through all throughout your body. It does work because you have estrogen receptors on your skin as well. And so they respond to it. They make it more plump, increase vascularity to the area. Is it the fix-all for everything? No. What I would say is using that, consider your Botox, your lasers, your microneedling. Really pay attention to your skin because that's like the thing that we see and it is impacted by menopause. So start to invest more in that area so you feel great about yourself, but estradiol or estriol or estrogen creams for face are good and they are safe. Yes.
I'm getting some. That's been on my list, but I just don't have 2 seconds to actually even go to the dentist. So.
Right. That's me. That is me. Yeah.
Okay. Any thoughts on taking adaptogens like ashwagandha while also on estrogel, prometrium, and testosterone? Feel as though the HRT doesn't help so much for mood related symptoms.
Say that one more time. You put a lot in there.
And
Which,
yeah, this I'm just reading this how they wrote it. And any thoughts on taking adaptogens, particularly ashwagandha, while also on estrogel, prometrium, and testosterone? But she
yes,
feels
okay.
like HRT doesn't help so much for the mood related symptoms.
Great. Okay, so now I get the question. So yes, ashwagandha is an aptogen. I think aptogens are wonderful as natural substances, and they really help balance some of the other things that are going on in life. As much as a hormone advocate that I am, there are other things that we can be taking that can also supplement or help them rather. So yes, as an aptogen, that's completely fine to take. The one thing that I would say about if you feel your hormone replacement therapy isn't working for you, then you need to find someone. And if someone's not adjusting it for you in the manner in which you need it, because it's personalized, it should never just be everyone's on the same dose. So someone may need to adjust that for you. But aptogens are a great way to kind of balance and use natural ways to create more of the substances in your body and the hormones to respond better. So yes, you can take that at the same time. There's one on here that I want to answer. How do you know if you're insulin resistant? When you get those labs that I talked about earlier, hemoglobin A1C is a good way to tell where your body is how it's processing sugar, I guess you could say, or glucose. Get a fasting insulin and a fasting glucose, because then you can do an insulin glucose ratio and see how your body is actually absorbing, utilizing glucose. That can give you a good idea if you're going more towards insulin resistance than not. But just in general, everyone, their body biologically just starts to get more
That's all.
insulin.
Thank you.
Yeah.
Okay, fabulous. Is there a minimum known estrogen dose, estrogel or estradiol for osteoporosis prevention?
Oh, that's a good question. There's no minimal dose. The goal really is to get you started on it. And the reason why I say that is how we measure bone mineral density is through like a T score and a Z score, which is arbitrary. You don't need to know about that. But everyone kind of has a score of where they are. So a lot factors into where you are, your age, your ethnicity, if you're a smoker, and also like your DNA, like, you know, your family history of what your bone structure is made up of. So there's no minimal dose. We're really just trying to improve who that person is and where they are based on all those things that I mentioned. So estrogen is going to help, but there's no minimum dose.
Okay, we are almost done. How does being overweight affect symptoms of perimenopause? I'm on HRT for improved sleep, joint relief, and minimizing hot flashes and night sweats. It works, but I've gained 5 to 7 pounds since starting HRT a few months ago. Is there a correlation between weight gain and worsening perimenopausal symptoms?
Yes. So there are some people who, when they start HRT, can start to have this like slight little bump with that 5 to 10 pounds. Most times it is transient meaning that it will even out. The other part of that is progesterone, again, the comfy hormone, does sometimes like to absorb water, right? And so you may be more water retaining because of the progesterone. So things, or to offset that, would be, again, with weight training, is going to build your muscle, increase your protein intake, because that is, and your fiber intake. If there are probably 3 things that I would mention in dietary to focus on, obviously there's a lot more. Vitamin D, making sure sometimes you mix it with ADK so that it's absorbed in the intestine. Vitamin D, protein intake, and fiber, right? Remember we talked a little bit about gut health. So again, making sure that we're keeping our gut in the most healthy way so that we're not, again, losing things that we want to keep in and things are coming in that we don't want to come in.
Yes. Okay, great information. Is there a chance of inflammation in joints increasing significantly as women approach postmenopause, in particular the hand and finger joints?
Yes. Inflammation, there's a great company, if you wanted to look it up, it's called GlycanAge, GlycanAge. They're not the only one who does this, but what they actually look at is from your biomarker. So they take your blood and look at your inflammation factors, because there is such great data as we start to decrease in estrogen, inflammation increases. So two things cause inflammation. One, well, actually a lot does. Our diet, our age, as we start to age, we just become more inflamed. And then also menopause contributes to that as well. So many women start to have joint issues. I have a lot of women who that's their presenting symptom of menopause. We get them on HRT and their joints are not as achy. Musculoskeletal syndrome of menopause is real. Most people might complain of a frozen shoulder, but joints are also part of that as well as lower back pain too.
Okay. What would you recommend for vaginal dryness? HRT or another natural way?
Ooh, I love this because I do all of them in my office. So vaginal estrogen. So it would be you're not going to get as much bang for your buck. Let's say if you take systemic HRT, like a pill, a patch, a cream, vaginally. But a vaginal estrogen cream, yes. There also is the laser, a CO2 laser that can really help restore a lot of the vaginal tissue. And then there's also radiofrequency, which can also help get to the deep layers of the tissue in the vagina to help restore the vascularity and also secretions. And then PRP injections we can do that for hair, we do it in face, but we can also do it vaginally as well to kind of help restore that. So that's like 4 great different ways that you can do it if someone wanted to do HRT and a blend of some of the other things, or non-hormonal and investigate the other 3.
I mean, thank goodness for this day and age, right?
Right, I know.
Okay, almost done. I'm 51 and for the last year I've been on birth control to help me with perimenopause and have very heavy periods. I had an ultrasound prior to rule out other causes of excessive bleeding. I've been fine on birth control and the pills are controlling my periods, but I'm wondering if I should switch to HRT. Okay, so that's another over the counter. So probably time to talk to her physician about possibly switching.
Switching
to HRT.
From what though? From nothing?
Birth control pills.
Oh, yes. So she wants to, but she's unsure of what?
Yeah, she has very heavy periods, so I think that's why she's been on the pill. She's been doing fine on the pill, but then wondering if she should switch to HRT instead.
If she has heavy bleeding, I would navigate another form of birth control because she's not going to get the control of bleeding with the HRT. So really, and I say this because I have one myself, but an IUD is a great way to control bleeding. And then you could still go on HRT. There's also medications for heavy bleeding that are just for the heavy bleeding. And then you can kind of do the other stuff, which would be HRT. So I think that, or small procedures. So it's not a surgery, but there are small things that can actually help with heavy bleeding as well. So that one actually has a longer cascade, I guess, of lists that can be done for that part while considering, do I switch over to MHT? So it's 2 separate categories. The bleeding is a category that needs to be addressed with medications, non-medication or non-hormonal medications or procedures. And then the other side would be, do I stay on birth control or do I switch to MHT? 2 separate things.
Yeah. Okay. What effect on menopause does an IUD have for a woman in her mid-40s?
Say that one again.
What effect on menopause does an IUD have on a woman in her mid-40s?
Great birth control and no bleeding. That's coming from a personal experience. It really was designed to be like this really great local way to decrease bleeding, provide birth control that's low maintenance because you don't have to take something every day, change something out. But it doesn't have an impact on menopause. It helps with the bleeding portion of someone who's perimenopausal and also provides birth control while you can still address considering MHT in the perimenopausal phase if you wanted to.
Okay. We're wrapping it up. What are your thoughts about when this person entered menopause? She started experiencing recurring UTIs and urgency incontinence. Do you recommend hormone therapy for women in similar situations?
Yes, because the bladder, remember we were talking about the sphincter and how it doesn't control, it's not as tight as it needs to be. So in the moments when we're trying to hold our urine, it's still a little open so urine can come out. HRT can definitely help restore some of the tissue in the sphincter and in the urethra. The other good thing in why, even if it doesn't correct it, even if you needed a procedure or a laser or something else, You're now being preventative by using HRT, namely vaginal estrogen in this instance, because as you start to get older, it's only going to become more of a problem. And, quick statistic, when you look at actual old age homes, most of the women, a lot of times there, usually are having issues with chronic UTIs because of either losing urine or their bladder's not working to the best capacity that it can because of the microbiome in the bladder, because it's no estrogen is being provided. And that actually can lead to so many other mortalities and diseases and issues in older age for women. So protect your urethra. Consider vaginal estrogen as both helping with symptoms and also being preventative for later on in life.
Okay, fabulous. 2 more quick questions. If a woman went through menopause 5 years ago, is it possible to start HRT to treat lack of libido? Is it too late, or is it too late to start?
I always say it is never too late to try anything, because at the end of the day, if it works for one but doesn't work for another, like, we still tried. And I think that testosterone is a beautiful way to restore a hormone that was already there. Women have testosterone. We are just put in this category where, everyone thinks that we don't have it and only men have it. But we should be just as happy to be the sexual beings that we are, and that should not decrease with age. And so I think it is always worthy of someone to consider starting testosterone therapy and considering to increase dosage until they might feel that they do have their libido restored, and not to give up on that.
Oh, I love that. I hope this is considered general enough. I wondered if you could touch on how fibroids affect active women. What lifestyle changes should we be making if we develop them?
Yeah, fibroids are actually up to 70% in Black women and 50% in women of all ethnicities have fibroids, right? So a lot of it has to do with, when we think of fibroids, we think of size, amount, and where they're located. So most women, if you listen to those statistics, either half or most women will have fibroids, but most of us don't even know, right? But 25 to 30% of women are symptomatic, meaning they're big and they take up size, or they have heavy bleeding. So there are really a lot of modalities that are out there to help with the symptom if you do have a symptom. If you don't have any symptoms and maybe on an ultrasound saw that you had fibroids, typically we can be like, okay, if they're not bothering you, we can kind of just monitor them. If they are causing an issue, so many different modalities that can help with the symptom that it's causing, because there are multiple symptoms that can cause. But throughout the perimenopausal phase, I would say that fibroids sometimes can start to wreak havoc because our hormones are doing that roller coaster. Remember how we started, the roller coaster ride. And that can actually create heavy periods for people who are like, I never used to have heavy periods. And all of a sudden they start to have heavy periods. Could be a cause of the fibroids that are being responsive to these hormone fluctuations. But a lot of women have fibroids. They just don't have symptoms.
Jessica, I adore you, and I'm so grateful, and I'm so sorry we kept you a few minutes over. Thank you so much. I mean, so many of these questions, not only, I didn't have time to really read the thank you for all you do, Dr. Shepherd. So I was just like trying to get to them, but so much love from this group of women, and so much love for what you're doing and just who you are as a person and a physician. So thank you, thank you, thank you. I can't wait to track you while you're experiencing Ibiza, and have fun while you're there, along with work.
And I can't wait for us to get together. I hope everyone who's on here, thank you for investing in your health and being here. But when you see Hailey and I together next time, she will be busting my butt. And then you guys can be like, wow, she's really kicking her ass. I'll be like, yeah, that's what she does.
Exactly. We're making it happen.
Yes, we are.
Okay. I adore you. Take care. And thank you so much.
Everybody. All right. Have a good night.
Travel safe. Okay. Bye. Thanks for listening.
If you enjoyed this episode, please consider giving us a 5-star review and sharing the Body Pod with your friends.
Until next time.